this is a matter of life and death, and making these decisions, judgments based on the best possible, uh, information available uh, may make a huge difference. All right, so I start with a case history as an example. A 50-year female presented with breast lump, right? So this is uh, oh, okay. This is how biopsy looked like, and you see that here, this is the normal breast lobule, right? And here is the tumor. So, what do you think? What it looks like? Huh? Ductal carcinoma in situ, you mean? Comedo type. So that's what the trainee who showed this case to me uh, said, that this is DCIS, ductal carcinoma in situ, right? So this is that normal lobule at the periphery, this one, at a higher magnification, okay, having the double layered epithelium, okay, and this is the what she called and you are calling ductal carcinoma in situ, comedo type, okay. So I said, why don't beta मैं करूं? Okay, that why can't we do a myopithelial stain, and you know that one of the good ones, one of the good ones is P63, because it stains the myoepithelial cells as nuclear staining, right? Smooth muscle actin, sometimes overstrains and there may be problems. So this is normal lobule, and that's what you will expect, that it is double layered, right? You see the epithelial layer and the myoepithelial layer continuously around all SN, right? So that's what you will expect. However, what you were calling DCIS, there is no myoepithelial staining, right? This one will qualify as DCIS, maybe solid type, because you see the continuous myoepithelial layer, right? But here, it looks like ductal carcinoma in situ, but where is the myoepithelial layer, right? This is another case, very similar. Again, the trainee brought this as saying it shows extensive ductal carcinoma, comedo type in situ, and I'm not sure that if there is any invasion, maybe somewhere here. But I said, okay, let's first get the P16, the myoepithelial staining, and there is no myoepithelial staining because there is no myoepithelial layer, right? So, and where you genuinely have the ductal carcinoma in situ, you always have the myoepithelial layer, right? So what we were looking at, it is infiltrating carcinoma breast with central comedo-like necrosis, right? So actually, way back in 2007, I published 4 cases of this for the first time, that infiltrating ductal carcinoma breast with central necrosis closely mimic ductal carcinoma in situ a case series, right? So this actually led to a lot of further studies, and if you do to go to Google Scholar, there were many more articles on this, because this was a diagnostic trap, that if you are not careful, you will call it ductal carcinoma in situ instead of a high grade 3 invasive carcinoma. And in those cases, because it was uh, initially, uh, if initially called as ductal carcinoma in situ, there will be no role of HER2, because HER2 testing is only done on the invasive carcinoma, right? Now, case 2, 45 female, large bowel biopsy. So this is a large bowel biopsy, and the patient, uh, they were suspecting that it's a kind of a thickened, roughened wall, and history of dyspepsia and all that. With as happens in most cases, without any prior history. So, well, obviously, when the physician or surgeons, they raise the question of malignancy in a stomach, if you are not careful, it's very easy to miss diagnosis of signet ring carcinoma. And at the same time, if you are not careful, you may overdiagnose signet carcinoma. Many cells, sometimes even histiocytes may look like signet ring, right? So here, uh, at some place, it look, if you are in rush, most of the mistakes you make, when you are too busy or you rush things. I'm sure on low power, somebody will say, when it looks normal, no significant histologic abnormality is seen, or maybe at the most mild chronic non-specific gastritis. Next case. But because there was some history and there were some expansion there, so I said, just get some immuno. This is the higher magnification. And here I think you may see some large atypical cells, isn't it? These ones. They look as some tumor is infiltrating. They are not typically looking as signet ring carcinoma. So what could be this? We are talking about breast. Metastatic lobular carcinoma. That's cytokeratin 7, BRST, estrogen receptor, higher magnification. So, as you rightly guessed, it was metastatic lobular, and indeed there was a history quite some time ago about the mastectomy and all that, though the reports were not available. So lobular carcinoma, again because of the E-cadherin loss, it may invade easily, and stomach is one place, but even more commonly, in the endometrial lining, it may present as involving the endometrium, and obviously any organ. Right. So, what are the good markers of breast carcinoma in a metastatic setting? Right. If you are suspecting that could this be coming from breast, what immunohistochemical markers are good? I mean, it was estrogen receptor positive. Lobular carcinomas are always estrogen receptor positive almost always. However, uh, otherwise a good number of carcinoma breast may be negative for estrogen receptor, right? Now this mama globin, also called BRST, we have this antibody, but not a very good antibody. Rarely we will use that, as a vast majority of adenocarcinomas of other sites may also, uh, are almost always, it expressed in lung adenocarcinoma. However, vast majority of others are negative. So, you know, not very sensitive, not very specific, in other words, right? Mama globin A, sensitivity of this is somewhat lower than BRST, and it may also be expressed in about 10% of ovarian and endometrial carcinomas, right? So again, when you start your immunohistochemistry and you want a critical uh, number of antibodies you would like to order, uh, for breast I won't go into neither for BRST nor for mama globin. The best is GATA3, right? A very sensitive and specific marker for breast carcinoma. Sensitivity is about 91% for ductal and 100% for lobular carcinoma. Right? So GATA3 is the best marker. Additionally, unlike GCDFP and mama globin, GATA3 expression is also uh, seen in significant cases of triple negative breast carcinomas, because that will be a challenge. They will be negative for ER, PR, HER2. So in that case, still the sensitivity is so good that even triple negative carcinomas, most of them will stain with GATA3, right? The only other tumors, and Dr. Zishan is here, which will stain for GATA3 are the, can we remove this? Oh, okay. Are the urothelial carcinomas. Urothelial carcinomas of the bladder, ureter, what we previously called transitional cell carcinoma, now it's recommended to call it urothelial carcinoma. They are also GATA3 positive. But the good thing is that they hardly ever come in the differential diagnosis. I mean, the chances of carcinoma breast to metastasize to the urinary bladder must be exceptionally rare, isn't it? So, GATA3 is a good marker. Okay. Now, pathologists' role traditionally have been as a diagnostician. But since a long time, our role has been extended. And that in one way is highly beneficial. It has made our specialty very important and very interesting. And the kind of approach that, we already have enough and leave it for somebody else, is not a good idea. One has to own it, learn it, because pathologists are the only people who can interpret any morphology on H&E, for instance, any immunohistochemical marker. Nothing is specific. If you say this is 100%, for 100% you have to bring Allah, which is not possible, because there are always cross reactivities. So it's the best judgment, taking into account the clinical perspective of the case, what you are looking at, on H&E section, the morphology and any kind of mutation or immunohistochemical expression and so on. No other physician can do this. And that's why our role has become very important. Because now, I will touch in my future, one lecture as well, uh, that now, you know, chemotherapy. In cancer, chemotherapy, what is chemotherapy? Chemotherapy are a bunch of drugs which are actually poisons, right? I mean, they will kill anything which is growing, which is dividing, which is proliferating. That's why, when you give chemotherapy, not only the cancer cells become dead, but any cells which normally are replicating, uh, like bone marrow, so bone marrow suppression, your hairs grow, so hair fall, you know, your gut stem cells all the time are replacing the old enterocytes, so diarrhea. So now things are becoming more, uh, what you call precision therapies. And you look for that what is driving the carcinogenic pathway. If estrogen, there are two cancers in females which are estrogen dependent. One is breast cancer, other is the endometrial cancer. So if estrogen is overexpressed, you should treat after whatever surgery, etc., by keeping the patient on anti-estrogen therapy like tamoxifen, right? If the carcinogenic pathway is HER2 oncogene, then the patient must get anti-HER2, which blocks monoclonal antibody, humanized monoclonal antibody, which blocks HER2, what you call Herceptin or trastuzumab. Otherwise, the prognosis will be very poor. If there is a BRAF mutation, you come up with the anti-BRAF antibody. If there is a ALK mutation, there is a treatment, specialized treatment available for that. If it's a chronic myeloid leukemia 922 translocation, you come up with the drug Gleevec, for gastrointestinal stromal tumor at express CD117. Gleevec is used. So the medicine, particularly the cancer medicine, is moving not a one treatment for all breast cancer patients, but depending what is driving the carcinogenic pathway, right? So pathologist's role in this is extremely important, right? Okay. Estrogen receptor. There are 3 tests. As soon as a breast cancer patient is diagnosed, 3 tests are immediately requested. And to have not those tests available will be ethically very difficult to defend, in peacetime. Estrogen receptor, progesterone receptor, and HER2 status, right? 100% of the breast carcinoma patient, they must get tested for these 3. Estrogen receptor, let's come to the estrogen receptor. It plays an important but limited role in the identification of the primary site of carcinomas presenting at a metastatic site, given that ER is expressed in only about 2/3 to 3/4 of primary breast cancer patients. So in diagnosis, its role is limited, obviously, because it may be ER negative. Also, ER can be expressed not only in carcinomas of hormone responsive organs like breast, ovary, and endometrium, but also in unexpected sites such as papillary carcinoma of thyroid may express estrogen receptor. Most critically, about 10% primary lung adenocarcinomas may show focal. So in metastatic setting, as I mentioned, GATA3 is one of the best markers, not estrogen receptor. Now, always when immunohistochemistry is done for estrogen receptor, a built-in control will be most ideal, because then you will know that your antibody is working, right? For example, you see, uh, this is a uh, carcinoma, a very well differentiated carcinoma, forming tubules and very strong staining with the antibody against estrogen receptor, right? Here, uh, if this is the normal breast and this is the tumor, and if your normal breast is showing the expression of estrogen receptor and the tumor is negative, then you are sure that your tumor is truly negative because your built-in control is working. So you are sure, right? So always try to have a normal breast lobule on a specimen of breast cancer for estrogen receptor and progesterone receptor testing, right? And these are two of our cases, also in the chapter of predictive histopathology in Atlas, strong diffuse stain. And this is a fortune, because uh, after whatever treatment, you keep the patient for many, many years on a rather that which blocks estrogen receptor like tamoxifen, so that the chances of recurrence becomes very low. The problem with the cancer is that most cancers will go into remission, temporary remission with initial treatments and chemotherapy, but there is always more disease than it looks. And in many cases, it comes back, and when it comes back, it comes in a very ugly form, not responsive to anything, and that is very bad news, right? So you always take into account the number of cells stained and the intensity of the stain, right? I mean, this was a paper which I published quite some time ago, and that also somehow, because of the nature of the topic, has gained quite a bit of attention, that estrogen receptor alpha negative and progesterone receptor positive breast cancer, lab error or real entity. Progesterone is an estrogen-induced protein. So if a tumor breast cancer is both estrogen receptor and progesterone receptor positive, it means that this pathway is functional as well. And the anti-estrogen therapy will do even better, right? So it will be uh, hard to imagine a tumor which is estrogen receptor negative and progesterone receptor positive. So always in that case, I always get the estrogen receptor ER repeated, and even if on the second go ER is negative and PR is still positive, I will write a note that a very small percentage of patients genuinely may show progesterone receptor uh, positivity and estrogen receptor negativity, and there may be multiple reasons for that. Uh, and one of the reasons which I noted initially was that the antibodies which we use from DECO mostly, the the uh, the what you call it, the affinity of the antibody with progesterone receptor was much better compared to estrogen receptor. So always if you do a tumor which is ER positive, PR positive, the PR staining is much brighter than ER staining. So maybe if the estrogen receptor is not that much expressed, it's a weak estrogen receptor with an antibody, it may not come to the detection level. So these should get benefit, in other words. You may have about 5% of the cases where ER may be negative, PR positive. They shall also get and must not be deprived of the hormone therapy. Oh, this is the crux of this talk. This is a story not from a developing country like Pakistan or Somalia or any other third world country. This is a story from Canada, you know, one of the supposedly most advanced and developed country. Ontario. Actually, what happened that a it says that you may even read that a nurse was diagnosed with breast cancer, and you know, all ER, PR, HER2, everything was negative. However, and the doctors there, they said, you know, I mean, prognosis is very bad and she is not going to survive. However, you know, she was told by her oncologist that no further treatments are available for her. Her husband, a physician, pushed for a second opinion. So her oncologist emailed. So Sloan Kettering Memorial and MD Anderson are two very popular cancer centers in the United States. So, and asking, you know, that she is told that nothing is going to work, and do you have any clinical trials where she may enroll? Because what happens that if nothing works, in developed countries, always some clinical trials are going on. So there is an opportunity if one may enroll in a clinical trial and something by chance may work. And the oncologist briefed the pathologist there at Memorial Sloan Kettering that she is diagnosed with lobular carcinoma breast, which is ER, PR negative, ER, PR, HER2 negative. The pathologist immediately said that if it is truly a lobular carcinoma, then it can't be ER, PR negative, right? Either one thing is for sure incorrect. Either this is not lobular carcinoma breast or ER, PR testing is not optimal, right? So that led to a huge investigation in the whole Ontario area. And I think several thousands of cases which were tested for ER, PR were reviewed. And in fact, they found a good percentage, I don't remember, at least maybe 10 to 15% were incorrectly reported. So then a report was published, and which is revealing, and the salient features I'm showing you here. The precarious path to diagnostic accuracy, the Ontario Hormone Receptor Guidelines. They say the final report from judicial review, it was a, you know, came in the media, a very popular, you know, trial, and at that time, in which obviously the judiciary was also involved, and led to a lot of compensations and so on. It describes a remarkable catalog of errors in which poorly organized, badly paid, overworked, undereducated, and constantly changing staff failed to adopt continuing education, clear protocols, quality assurance, or results monitoring. So it seems that we are talking about something, a country like ours, but this is Canada. And overbearing management was preoccupied with saving money and had little interest in the technical aspects of the service that was being delivered. Typical. When the scandal erupted, there was an inept attempt to uh, there was an inept attempt to conceal the extent of the discrepancies, which fueled media interest, making it a national news item in Canada for years. Right. Following the initial test validation, there should be. So, what are the requirements for assuring ongoing ER/PR testing quality? This came in the recommendation of this, Ontario. Following the initial test validation, there should be ongoing quality control and equipment maintenance. There needs to be ongoing training and competency assessment of both technical staff and pathologists. ER positive and negative rates should be trended by pathologists, by patient age, and by tumor grade. This is very important to use your judgment. Like as a rule of thumb, classic lobular carcinomas will be always ER/PR positive, strong positive, and HER2 negative. Though pleomorphic lobular carcinoma may be ER/PR negative and HER2 positive. That's an exception, right? So that kind of judgment. Mucinous carcinomas of the breast must be always ER/PR positive. Tubular carcinoma of the breast. So if someone reports negative, that should be questioned, right? Overall, ER negative rate should be less than 30%. In women over 65, ER negative rate for invasive tumor should be less than 20%. Now this is again very important that in postmenopausal women, the chances of a negative carcinoma breast, in particular if it's not more than grade 2, should be low. More ER negative breast cancers are seen in premenopausal women. So if a 65 or 70 years old woman and grade 2 breast carcinoma, ER/PR comes negative, you should be careful, right? What happens that somehow in young women there is a circulating estrogen, lot of circulating estrogen that occupies the estrogen receptors already, so it's not accessible. In postmenopausal, estrogen goes down as far as concerned in the blood, so it's more accessible. So post-operative should be, if you test 100 cases, there should be not more than 20 cases negative. In premenopausal, 60% may be negative, right? Okay. Low-grade tumor, ER negative rate should be less than 5%. And as I said, nothing is 100%, but less than 5%. Participation in external proficiency testing with at least 2 testing events per year is mandatory. Because here you are making major decisions, what therapy you are giving. Satisfactory performance require at least 90% correct responses on graded challenges. Our lab is College of American Pathologists, CAP accredited. So, but even before that, for a very long time, for 30 years at least, we participated in the CAP programs. They send the slides, which we stain, score, and then they give us the feedback. So we get for ER, for PR, for HER2, for flow cytometry, in addition to surgical pathology and cytopathology. Okay. Because in their country, or in countries like UK, if your responses are less than 90%, less than 90% are correct, they will seal the lab until that what's going on, it's not acceptable. In our countries, there are no such consequences, but that's shame. Again, tissues submitted, worldwide today, all immunohistochemistry whether for diagnostic or predictive or prognostic purpose, is optimized on 10% buffered formalin, right? So if it is received in somehow, which would be unusual, in any other fixative, then it may affect the testing, right? So, and this should not be done, and the sample should be rejected. Again, samples with prolonged cold ischemia time of formalin fixation, both under fixation is bad and over fixation is bad. Under fixation less than 6 hours is, may affect the result, and over fixation, particularly more than 72 hours. Actually, what happens that, as you know, that formalin fixes by cross-linking the proteins. So it masks the, antigenic site and may lead to false negative result, right? So this is important. There are only two categories for adequate ER or PR immunohistochemical results, negative or positive. And currently, less a tumor which shows more than 1% of the tumor cells positive, we call it estrogen receptor positive, right? 1%. Okay, but I will show you that a little change which came recently. What are the criteria for rejection of results? We have already talked about. A result that is ER negative and PR positive should call into question the result, and hormone receptor studies should be repeated on a different block or specimen if available. I already talked about this, that this should be unusual, that PR positive, ER negative. Decalcification. Breast tumor commonly goes into the brain. And this is not uncommon that the first diagnosis is made from a biopsy taken from the spine bone, commonly metastasized there. In female, if there is a metastasis, in females, there is a backache and, problem. The first thing I will think in female is this the breast metastasis? In males, you will think of prostate, right? Other tumors which commonly goes to bone include thyroid, follicular carcinoma of thyroid, not papillary. Papillary goes to the lymph node, and kidney tumors, renal tumors, they commonly goes to brain, to bone. So decalcification. The findings should be correlated with the histologic type and grade. That's here where the judgment, comes into place. The study should be repeated if the results are discordant. For example, ER negative tubular carcinoma or grade 1 or 2 lobular carcinoma. This should be questioned because 95% chances that they should be positive. So what are the implications of false negative and false positive results? False positive hormone receptor studies are unusual actually. False negative is more common, but could subject a patient to endocrine-based therapy that would offer no benefit and subject the patient to an increased risk for possibly fatal thromboembolic events and uterine cancer. I mean, estrogen, we know, is carcinogenic, right? So these therapies like contraceptives, a common side effect has been the thromboembolic phenomena, right? So these drugs also, if you give unnecessarily, instead of getting benefit, because there is no benefit, it increases such risks. And false negative results are thought to be too common and deny patients the substantial benefits of endocrine therapy while simultaneously misdirecting therapy to potentially toxic alternate therapy. So then they have to go to, platinum-based and this-based chemotherapeutic agents. As I said, these are actually poisons. There is a common saying that all drugs are potential poisons and all poisons are potential medicines, right? there is a sometimes very delicate, thin line between the two. I mean, any drug, if you take excessive dose, it may kill you, isn't it? So ER-PR scoring, there are several. We use LRAD scoring, in which we take into account the number of cells and the intensity. However, as a general rule, a score more than only one cell is positive in this case, and the intensity is very weak. A score up to 2 is taken as negative. Another percent, probably this is good for quality control, but more than 1% cells positive, you call it positive and give the benefit of doubt. However, with the NGS, next generation sequencing, what happened that in the past few years, in developed countries, even in developing countries where people can afford, they send the blocks of the breast cancer for next generation sequencing. And it was found that weak positive ER and PR given based on immunohistochemistry turned out to be consistently negative on sequencing, right? And you see, what you call this? This is completely negative. This is strongly positive. And what about if you have some very weak staining? So the recommendations of the College of American Pathologists are that more than 1% is still kept, but less than 1% called negative. 1 to 10% are called positive with a qualifier that this is very weak positive. However, she may still benefit from the hormone therapy with a qualifier, right? And more than 10% we will call positive. So now this is the third category which is introduced by ESCO and CAP, that 1 to 10% positivity must go with a qualifier because they may not respond to the tamoxifen and anti-estrogen therapy. Okay, now coming to HER2, I think I will finish in 10 minutes. So HER2 is one of the most characteristic and best studied proto-oncogene. In about 15 to 20% breast cancers, they show amplification of this gene. And that is the carcinogenic pathway, HER2 driven. HER2 is a part of the EGFR family, right? And they don't respond well to the conventional chemotherapeutic agents. So in 90s, it was the first humanized monoclonal antibody which came into market. And if in developed countries, if the breast tumor is truly HER2 positive, she must get Herceptin or trastuzumab or anti-HER2 antibody, which otherwise it will be kind of criminal, because they die quickly if they don't get this. So HER2 is a normal gene actually, proto-oncogene. Why we call it proto-oncogene? Actually, what happened that during cancer research, some genes were found, in cancers, and it was thought that they are the cause for, cancer, and they were called oncogene. But at the turn of the century in 2000, when the whole genome was sequenced, it was found that the same genes are normally present in our genome and perform very important functions. So they were called proto-oncogenes. But proto-oncogenes are normal genes. However, there are 4 ways by which, I will come to that, normal proto-oncogene may become or behave as oncogene, right? So this is the member of the EGFR family. You see that HER2 driven, so this trastuzumab, it blocks that. Okay. So HER2 gene amplification is seen in about 15 to 20% of breast cancers. So all breast cancers must be tested for HER2. You see that the carcinogenic pathways, and you have to identify which one is involved and block that, right? And these were the guys, actually first who discovered this HER2, and next who came up with this precision therapy. So it is the prerequisite in the clinical management of patients with breast cancer in order to obtain prognostic and predictive information, including Herceptin utility. Scientific rationale: gene amplification correlates with protein overexpression in the majority, 95% of the breast cancer. So first you test with the immunohistochemistry, which is quick, cheaper, using an anti-HER2 antibody, right? And then if it's a equivocal result, then you go for FISH testing, fluorescent in situ hybridization. Carcinomas with gene amplification are more likely to respond to HER2-directed therapy. So these are the 4 ways by which normal gene may become or behave as oncogene. The most common is point mutation. Just by random error, one nucleotide is replaced by another nucleotide. This is called point mutation, right? Very common, like RAS, Second is gene amplification. Normally, we have all chromosomes are in pairs. So HER2 gene, normally 2 copies on 2 arms of chromosome 17, right? But if there are multiple copies, it means that gene is amplified, leading to more HER2 protein, more growth and cancer, right? Third is like viral insertion, which act as a promoter to alter the gene expression, And fourth is the gene translocation, like in Burkitt's lymphoma, the normal gene is translocated to another chromosome, like c-MYC in Burkitt's lymphoma. Normally it is present on chromosome 8, but in about 80% cases of Burkitt's lymphoma, it translocates to chromosome 14, come under the influence of a very active gene, immunoglobulin heavy chain gene, IgH, which is very active all the time because we are exposed to environment, gets upregulated, more c-MYC and cancer. So 4 ways. So what is the algorithm? You first do immunohistochemistry. IHC score 0 or 1 plus is negative. 2 plus is borderline, they should go for FISH testing. 3 plus, if there are robust quality controls, this may be taken as positive and Herceptin may be started. When there is a major discrepancy, the most common reason is that of one of the assays is incorrect. Okay. FISH, you know that you come up with the probe, which is complementary, and if those sequence is there, it will combine with that and you can detect it. So let's come to the, I will skip few things for sake of time and will tell you